Okay, so now we're going to talk about blood clotting, and we are going to discuss different types of factors involved in coagulation, how they are activated, how they form a clot, and importantly, how they are regulated, because you don't want them to be over clotting, of course, and you don't want under clotting, of course. Okay, so basically this is going to center around platelets. So our platelets are going to be very important in blood clotting. And the composition of the blood is just basically going to be made up of primarily cells and also a liquid portion. Most of the liquid, of course, is going to come from water. And then you're going to have different proteins inside of your plasma. So for your plasma proteins, we have down here the major ones, which you are already familiar with. We have serum albumin. We have very low density lipoproteins, high density, low density. We also have immunoglobulins, and we have some of our clotting components. And then with respect to our cells, of course, we have mostly red blood cells, our erythrocytes, and then we also have leukocytes, and then a pretty large portion of platelets in the blood. So your plasma, which is the basically the distribution of water between a plasma, is basically the liquid form, and it contains a large portion of it is referred to as plasma proteins. And these are going to be not only the proteins we just talked about, but also this is how your electrolytes move, these are how your hormones move. And you're going to have the same electrolyte composition in your plasma as you would have in extracellular fluids. So plasma electrolytes equals your extracellular fluid electrolytes. So when you have a disease, oftentimes this is presented in your plasma proteins. And so you can collect plasma and test for different types of compositions of proteins in your body to see what kind of disease state it is. Now, another important thing about your plasma is that it's going to have an impact on osmotic pressure. So osmotic pressure that is going to be exerted by your plasma proteins is going to be critical or essential for bringing water back into the blood from the tissues. Put exert in. So it's not just important, it's actually critical. Okay, so albumin, as we know, is a major protein in the serum in your blood, and it is about 60% of the total protein that is going to be found in your plasma. It's also made by, of course, the liver. And albumin is able to get things through your blood that might otherwise not. They might be used up, degraded, or not get where they're going because they're going to interact with actual water molecules. So plasma can carry our fatty acids, so it makes them more soluble. And it could also carry your metals, anything charged that would interact with water, it can help get through, etc. So albumin is a major protein, but there are other proteins that are going to be made by the liver and they're in the serum. You have ceruloplasmin, which is going to bind to copper. We have our corticosteroid binding globulin. Again, that's a form of serum albumin. There's kind of a globulin-like molecule that will help bind cortisol and get it where it needs to go. We have haptoglobin, which is going to be important for heme, We already know about our lipoproteins. We have other globulins that are important for binding to other hormones, as well as transferrin, which transports iron. So with respect to other proteins, I'm not going to go too much into these. These are primarily immune. So you have from your liver, you will have your complement proteins. And these are released in their inactive form, and they have to become activated. We have from our B cells, we have antibodies. And then over here on this side, of course, we have our platelets. Now, platelets are simply just a blebbing of your megakaryocytes. So they basically just break off of your megakaryocytes, and so they take with it whatever the megakaryocyte was making. So we're not going to talk, of course, about our immune portion, but we are going to discuss our platelets today. All right, so our plasma proteins are going to be critical for maintaining the integrity of our circulatory system, as you all know. And survival is going to require the ability of the body to control blood and its flow. Hemostasis is the process of blood clotting. Oops. All right. So you have blood clotting, then you have to dissolve the clot. And then you have to repair. And you have to repair the damage, and the damage can be actually in an actual tissue, the damage can be in a blood vessel or wherever it is. The plasma proteins produced by the liver primarily help to maintain this integrity within the circulatory system. Now, platelets are going to be critical for clotting. So this is platelets are going to be one of the major important, they're not cells, but one of the important aspects of the serum proteins that are going to be critical for clotting. And so everybody pretty much knows that. So if you get damage to the endothelial lining of blood vessels, for example, this is going to expose a subendothelial layer. And this subendothelial layer is going to be made up of extracellular matrix as well as smooth muscles. I'll first put subendothelial. And of course, we're talking about a blood vessel here. And so you're going to have to form a barrier, a hemostatic plug or clot will begin to form. And the platelets are going to initiate and bind to the damaged area, and then they're going to form the clot, and the clot formation is going to be tightly regulated. So platelets come from megakaryocytes. And when the megakaryocytes become 8 nuclei, so they're multinucleated, then you start to make platelets. And platelets are non-nucleated. They're just simply fragments of the megakaryocytes membrane. So in essence, they're very similar to the red blood cell at this point in that they are only given whatever they could grab. Blood cells obviously are given what they make in their precursor forms, but platelets can only get what they grab. So the ability to control blood flow is going to be important in, of course, our survival. Hemostasis, as we just talked about, is the process of blood clotting, and then it has 4 basic events. And so if the first is going to be some sort of injury, of course, and so you have an initiation phase. Which is going to be an injury, and this is followed by some sort of blood constriction, so vascular constriction to limit the blood flow. And then the second one is going to be where you have activations of your platelet. And this is going to be by thrombin. And this is going to form a temporary plug. And then you're going to have formation of a clot. Which is basically a fibrin mesh. And this fiber mesh can have it be called a white thrombus when only platelets are involved. Or it can be a red thrombus if both platelets and red blood cells are involved. And then finally you have dissolution of the clot. And this is going to occur via plasmin, and this will allow for normal blood flow to return. Okay, so we're going to go into intrinsic and extrinsic pathways of clot formation, and then the clot will be formed. And before we get to do that, though, we have to talk a little bit about the platelet and what it is doing. So as we mentioned, the platelet is non-nucleated, and it has a major role in forming a mechanical plug. Okay, and so this is where you're going to have a need at a site of injury. Now, the platelet also has a bunch of proteins inside of it. It has a bunch of signaling pathways inside of it, which we'll talk about. And it has the role of secreting regulators for the clotting process and repair. So when your platelet is not involved in the clot, when it's just simply wandering around in your plasma, its membrane is extensively invaginated. So a platelet, circulating platelet, has an invaginated membrane, and this allows it to increase its surface area. And this is known as the open membrane tunicular system. Okay, and so the canicular system is just going to allow the platelet to interact more with its environments because it's going to have more of that surface area, as I said before. So there is also a system of channels, and these are referred to as a network throughout the entire cytoplasm of your platelet. And this system of channels has many different functions. And the system of channels are going to have the granules and the content of the granules that are going to be released when the platelet becomes activated. So it has the function of the network is to secrete platelet granules. It also has the ability to take up plasma proteins. Now, the platelets have three types of granules. Good, I have a whole thing on this. The platelet has three types of granules. They have what's referred to as an electron-dense granule, and they have an alpha granule, and they have a lysosomal granule. And remember, all of this came from the megakaryocyte. So the electron-dense granules are going to contain calcium. They're going to contain ADP, which is very important for platelets, ATP, and serotonin. And so you're going to find that a lot of the things that the platelet secretes, it's going to actually have receptors. So it's almost like an autocrine type of interaction between the granules and activation of the platelet. The alpha granule is going to have heparin antagonists. It's also going to have fibrinogen and something called the von Willebrand factor, as well as other clotting factors. This is von Willebrand factor plus clotting factors. And then the lysosomal granule are going to have hydrolytic enzymes, kind of what they always have. Okay, so I drew this some time ago just to sort of give you people an understanding of how complicated platelets are. They're not just these simple little fragments floating around in your blood. They're actually very biologically active when they become activated, hopefully only when needed. So platelets have a lot of receptors, and you can see that on their surface. These are all going to be G protein receptors. And you can also see here that we have the ability to signal with prostacyclin, which can counter thromboxane. So the platelet has the ability to counter itself also. So just keep that in mind. And it all has to go back to control. So let's talk about those two because we've had those already on our cosinoid lecture. So our prostacyclin is going to signal through a G protein S, which is a stimulator for cyclic AMP. That's what that S means. So it gets that sort of stimulated connotation because it's going through cyclic AMP and protein kinase A. Same story we've been talking about with glucagon, etc. But in a platelet, this is going to inhibit platelet activation. So prostacyclin is going to inhibit platelet activation, and we kind of know that because we knew it is a counter to thromboxane. And so thromboxane is going to signal through this G alpha type of receptor, and this is going to activate a protein downstream. It's the beta type of phospholipase C. So this is the beta type of phospholipase C. And you can see that there are other G alphas that also signal through the same pathway. And the purpose of this pathway is to activate diacylglycerol and get your protein kinase 3. And then this is going to lead to secretion of granules. And so thromboxane is going to lead to the activation of the platelet through secretion of the granules. Now, some other things that are going on is we are going to talk about thrombin, and we're also going to talk about serotonin. And I mentioned our granules inside of our platelet actually have serotonin, and it has ADP. And so they are using these to actually activate themselves. And so your serotonin and thrombin both have the ability to also activate that PLC beta, the beta form of phospholipase C. They also have, for thrombin, you also have ability to go downstream and activate Rho GTPases. Rho GTPases are critical for the shape of your cytoskeleton. And so the Rho GTPases help your platelets change shape. Serotonin is primarily going to have the same effect as your thromboxane. And then a very important signaling pathway for your platelets is through adenosine diphosphate. And adenosine diphosphate is going to use the P2Y12 G protein receptor. And this is an ADP receptor G protein for purinergic receptors. It's a family, and this 12 one happens to be on the surface of the platelet. And this is important for platelet aggregation. And it also is going to lead to a signal transduction pathway that's going to lead to thromboxane synthesis. And so in general, your platelets are extremely active. They have a lot of things going on when they start to get activated, and they also have some inhibitory things to control their activation. Okay, so what is going on with your platelets? So the platelets are going to become activated when they sense that there is a need, of course. And so a platelet is going to adhere to initially von Willebrand factor exposed on collagen. And remember, collagen is part of the extracellular matrix that will get exposed. Okay, and so the platelet will see von Willebrand factor and bind to it. So if you have, there are some deficiencies of von Willebrand factor, and this causes von Willebrand factor disease. And this is, of course, not going to be more associated with bleeding, because if you can't have your platelets binding to the site that gets damaged, then you're going to have excessive bleeding. Okay, so von Willebrand factor is actually going to be a bridge between glycoproteins on the platelets and your collagen fibrils. So von Willebrand factor is going to be located in the subendothelial matrix. The alpha granules will also contain von Willebrand factor, and von Willebrand factor is actually also going to be in the circulation just naturally. So it's found in the It's always in the circulation, and it has to be bound to clotting factor 8. So, of course, clotting factor 8. So your von Willebrand factor association with clotting factor 8 is going to stabilize, and it's actually required for clotting factor 8. Okay, so now adhesion of platelets is going to lead to a series of reactions within the actual platelet. And this series of reactions are going to lead to platelet activation. So what is going to trigger this is blood vessel injury, which exposes collagen. Oops. And then you get von Willebrand factor is going to be exposed as well. And the platelets are going to have glycoproteins on the surface that bind to von Willebrand factor as well as to collagen. So the platelets so we have, for example, we have our subendothelial collagen layer shown here. We have our platelet membrane shown here, and you have some glycoproteins. So GP is glycoprotein. That's what that stands for. So you have glycoprotein 1A. Let's do this one. So we have glycoprotein 1A. And glycoprotein 1A is going to bind collagen. And this is going to cause a change in the shape of the platelet, and it's going to get some long pseudopods that form. Now, there's also von Willebrand factor, which is going to bind to glycoprotein 1B. Okay, and that is shown here. You have 1B, which is binding to von Willebrand factor. And this is going to cause changes in the platelet membrane as well. And this exposes fibrinogen and von Willebrand factor binding sites. Oops. Okay, so your activation of your platelets is going to be induced eventually by thrombin. And um, thrombin receptors are going to be protease activated receptors, which are G protein receptors, and they're going to activate those downstream um, diacylglycerol that we talked about. And then we're also going to, at this time, activate those Rho G proteins that we talked about, which are going to be changing the cytoskeletal structure of the actual platelets. Um, Now, for the protein kinase C, is going to help in the adhesion of platelets to subepithelial cells, and it's going to do this via the release of platelet granules that we talked about. So we're going to have the release of dense and alpha granules, and this is going to help bring more platelets in, and you're going to get aggregation of platelets. One of the big aggregates of platelets is ADP, adenosine diphosphate. So basically, as the platelet gets activated, all of those G protein receptors on the surface we discussed are going to get sort of triggered, and you're going to get release of your granules. And this, one of the granules are going to contain adenosine diphosphate, and this is going to allow patients or platelets to come together. So why is adenosine diphosphate important? And part of this is because your adenosine diphosphate receptor on the surface of the platelets is going to trigger more thromboxane to be produced, as well as be critical to maintain platelet activation. So remember, eicosanoids are going to be degraded very rapidly. So if you don't keep the thromboxane going, you're not going to keep the platelet being activated. And your prostacyclin is going to turn everything off. So ADP keeps thromboxane. Oops. And this leads to enhanced platelet aggregation. Now, there are some antagonists for use in controlling thrombosis, such as Plavix. And Plavix is an irreversible inhibitor of that ADP-G protein receptor on platelet surfaces. So Plavix function is to prevent aggregation of platelets. So Plavix is going to be used for any of the peripheral vascular and cerebrovascular diseases, as well as coronary artery disease. Sorry. Okay, and so your platelets are going to adhere to the subendothelial layer. ADP is going to modify the platelet membranes, expose platelet glycoproteins receptor GP2B and GP2A. So glycoprotein GB Let me just do this. So we had just a reminder, we had GP1B, and this is on the platelet. Oops. And then this is your subendothelial collagen. And so the CP1B, remember, bound to von Willebrand factor. So it tethers to von Willebrand factor. And then we had the CP1A, or sorry, not C, GP1A, glycoprotein 1A. And that actually just bound to collagen fibers. So that binds to collagen fibers. And then when you get this going, you're going to have your signal transduction pathways activated, release of your granules, and then you're going to get ADP. And then ADP is going to expose to other glycoproteins on the surface of the platelets, and it's a membrane complex. And so here's your platelet. Just going to draw a line here. Here's your platelet. And so on the platelet surface, you're going to get a complex is glycoprotein 2B and glycoprotein 3A. So you're going to get this complex. Let me see. Sorry. And these guys are going to form a complex. And this complex is both a von Willebrand factor receptor and also binds to fibrinogen. And it induces fibrinogen-induced platelet aggregation. Okay, so the most commonly inherited platelet dysfunction is a disease known as Glazeman. Thrombocythemia. And this is a defect in this complex, the CP2B, CP3A complex. And in addition, you have antagonists of this complex, which are very potent inhibitors of platelet aggregation than either aspirin or Plavix. Now remember what aspirin's targeting. Aspirin, of course, is targeting cyclin oxygenase, which is then targeting thromboxane. Right, so that's what Plavix is targeting the ADP receptor. And so antagonists of this CP2B3A are targeting the complex that is going to not only bind von Willebrand factor, but also bind fibrinogen, which is a very potent inducer of platelet aggravation as well. And there are various antagonists for this. There's something called RioPro, which is a monoclonal antibody for this. There's integralin, and there's also agrestat, which are all going to be antagonists. So one is an actual drug, or it's not really a drug, it's an antibody, but it's used for therapy. And then we also have integralin, which is derived from a venom found in the pygmy rattlesnakes. And then we also have aggrastat. This is a synthetic organic molecule that can inactivate your complex by being an antagonist to it, binding to it. Okay, so now we're going to start talking about our clotting cascade. And so what we have to discuss here is the activation of intrinsic and extrinsic pathways. So basically, when you have contact between your blood and the exposed matrix, the exposed matrix has negatively charged surfaces. And so this negatively charged surface is going to trigger the clotting cascade. So, sorry. And then your extrinsic pathway is going to be initiated primarily upon vascular injury. So you have vascular injury, some sort of trauma, and this trauma leads to exposure of tissue factor. So tissue factor is actually factor 3, which is a cofactor for factor 7. So you have tissue factor, where should I put this? And this is a cofactor for the activation of factor 7. And then this is going to, tissue factor 3 is going to be a cell surface glycoprotein that's going to be able to have the ability to bind to phospholipids. Now, one thing to talk about when we talk about intrinsic pathway is that we have to look into the Kallikrein-Kinin system. This system is going to release vasoactive kinins. And we have pre-kallikrein. And this is going to be in plasma as well as tissues can make this. And these are going to be serine proteases who are going to have substrates as high molecular weight kininogen and low molecular weight kininogen. And so your pre-kallikrein is going to be activated to form kallikrein, which then will cleave your high molecular weight kininogen into bradykinin. And bradykinin is called the 9 amino acid vasoactive peptide. And tissue kallikrein also cleaves low molecular weight ganinogen into lysyl bradykinin. And this is going to be it's an A. And both forms of bradykinin will have the same fat function. They're both going to be vasodilators and increase vascular permeability. Okay, so intrinsic pathway, which is considered the contact phase. So for this phase, you're going to have clotting factor 12, clotting factor 11, pre-kallikrein, high molecular weight kininogen. And each of these are going to have different functions, and they're also going to have, some of them are going to have specific names. So clotting factor 12 is known as the Hagman factor. It is an endopeptidase and it's going to bind to collagen at the site of injury. It is activated by that high molecular weight kininogen and kallikrein. And then you have clotting factor 11, which is known as plasma thromboplastin antisense. This is also an endopeptidase. This is going to be activated by factor 12. We'll see that in just a moment. We have pre-kallikrein, which is also known as the Fletcher factor. This is going to interact with high molecular weight kininogen and factor 12 as well. And then, of course, we have our high molecular weight kininogen, which is going to be a contact activation cofactor. And this is necessary in activating factor 12 and factor 11. Of course, as we just saw, it is a precursor for bradykinin. So for contact phase proteins, basically, this is intrinsic. You have a vessel wall, and this vessel wall will expose negative charges. And then you'll have high molecular weight kininogen. And then this is going to activate factor 12. And this is going to become factor 12A. And you can think of the A as maybe activation. And so factor 12A will activate factor 11 to become factor 11A. Sorry, I should put this up here. Okay, and then so once you have those factors activated, so that's the start of the beginning of the intrinsic pathway. Again, we're talking about intrinsic. And then once you have that pathway activated, then you're going to get contact phase proteins activated. So from this, we're going to have factor 8. Factor 8 is an anti-hemophiliac factor A. This is known as a cofactor, so this is going to be required for the activation of factor 10. And then we have also factor 9, which is known as Christmas factor, or anti-hemophiliac factor B. And this is going to be an endopeptidase, and it key here, and why I have all this written, is to point out a few things. This is vitamin K dependent. And then finally we have our very important factor 10. This is known as the Stewart-Prouder factor. is an endopeptidase. It is vitamin K dependent. It's going to be activated by a process that includes tenase complex, and it's activated by factors 7A, as well as in the presence of tissue factor and calcium. So the tenase complex is going to activate factor 10. Tenase complex is simply made up of factor 9, 8A, and calcium, as well as 10. And you're going to find on the surface of platelets, you're going to have phosphatidylserine and phosphatidylainositol, which allows for the formation of your 10-ACE complex. So here we have our platelet membrane this time. And then on the surface, you'll have factor 8A. And this will be bound to factor 9A. And also factor 10 will be bound. So you're going to have factor 8, which in the presence of thrombin becomes that factor 8A. And then this is going to cause the release of factor 10. Okay, so the intrinsic factor is basically going to be your negative exposures. So these are charges that are exposed. And then you're going to have your factor 12 that gets activated by that high molecular weight. Kininogen. And this is going to lead to an activated 12, which then leads to an activated 11, which then leads to an activated 9 in the presence of calcium. And then this activated 9 is going to have the tenase complex. So we have our 8 with thrombin. Activate 8. So it goes to A, and then you have your 10 come in with calcium, and you get your activated 10. Okay, so other stimulators that are going to cause this intrinsic pathway are listed here. You have urate crystals, you have your amyloid B, homocysteine, and of course, some external damage by things like bacteria will also do this. Now, the development of atherosclerosis is very important. Remember, on the surface, you're going to have negative charges, and these are going to be mostly coming from phosphatidylethylamine, and this can be on circulating lipoprotein particles as well. So phosphatidylethylamine is going to be part of your chylomicrons, very low density lipoproteins, etc. And so negative charges will initiate the contact phase, regardless if it's on collagen or if it's on a lipoprotein particle. And that's going to be when factors 11 and 12 are exposed to any of those negative charges. And then this contact phase is going to initiate the intrinsic pathway. Okay, so now let's talk about the extrinsic clotting cascade. Now your extrinsic clotting cascade is going to involve that tissue factor that I mentioned very briefly. And so tissue factor is going to be a glycoprotein on the subendothelial cell surface that gets exposed and released, typically when you have some sort of damage or injury. So that's why it's extrinsic, because it's something causing a damage. And then you have factor 7, which is known as proconvertin. This is an accelerator of the conversion of prothrombin. It's an endopeptidase, It is vitamin K dependent. And it also has a need for calcium as well. We also have factor 10, Stewart-Prouder factors, same factor. So both intrinsic and extrinsic are going to converge on factor 10. This is activated again by that 10-ACE complex and also can be activated by tissue factor and calcium, which is what we're going to be talking about. So here we have a picture of your extrinsic versus extrinsic. So again, your intrinsic pathway had the high molecular weight kininogen, and that factor 12 that led to the activation of your factor 11, and that will converge on this 10-ACE complex in order to activate your factor 10. Extrinsic, you're using trauma in this case, and factor 7. Tissue factor is factor 3, which is going to be a cofactor for this. And this, again, is going to converge and activate factor 10 to factor 10A. So a thrombus or clot is going to be basically fueled by thrombin activation. And then all of your proteins listed here, all of your different factors are zymogens. Similar to your digestive enzymes, they have to be activated, so they're in an active form circulating in your body. And this is, of course, going to be very highly regulated. So some things to keep in mind are serine proteases in this pathway, because we have serine protease inhibitors. And so each of these factors will be inhibited with those serine protease inhibitors. We have our factor 7, which is shown here. That's a serine protease. We have our factors 11 up here. We have factor 10, which is what everything converges on. And we also have prothrombin. Oops, go get my pen. Sorry, I dropped the pen. And then I have listed here all the cofactors or cofactors that are important for, you can think about them as amplifying this blood coagulation cascade. And those are shown in blue. So your tissue factor is a cofactor. Factor 5 and factor 8 are all cofactors. Now, activation of prothrombin to thrombin, you're going to have a prothrombinase complex. The prothrombinase complex is composed of your phospholipids, phospholipid inositol, phosphatidylserine, and then also has calcium, and it has factor 5A, and it has factor 10A and prothrombin. So this is your prothrombinase complex. Okay, so factor 5 is a cofactor in the formation of the prothrombinase complex, and is activated by very low levels of thrombin and inactivated by very high levels of thrombin. Oops. Okay. So it's a level of control. Factor 5A is going to bind to specific receptors on the surface of activated platelets and forms a complex with factor 10A and prothrombin. So here you have your prothrombinase complex binding to prothrombin, shown here. Within the complex, your thrombin is going to be cleaved twice by factor 10A, and it generates a two-chain active thrombin, A and B, which are held together by a disulfide bond, single disulfide bond. So in this case, we were having now we have thrombin. And so thrombin can now signal, and thrombin is going to have several different transduction pathways. Thrombin, of course, can activate that Rho pathway, continue shape changing. It can also activate that beta phospholipase C pathway, and this can give you granule secretion, which is, of course, important to keep the whole process of clotting moving forward. Now, what does thrombin activation do? Well, you're going to have a lot of things happening. The first thing is you're going to have your immune system. So in your immune system, will release inflammatory cytokines. And they're called interleukins. So you get IL-1 and you get IL-6. They're both going to be pro-inflammatory. IL-6 can be both pro and anti. The second thing you get is you're going to get adhesion molecules activated. And these are known as ICAMs. So these are intercellular adhesion molecules. And these are going to be able to bind to immune cells, such as your monocytes, neutrophils, and granulocytes. And they bind to a series of molecules called integrins. And they're also the ICAMs are also expressed on your endothelial cells, so the immune cells and endothelial cells can interact as well. And then you're going to get your vascular cell adhesion molecules. Which are called VCAMs. And this allows adhesion molecules to be expressed via your vascular endothelial cells, and it allows for your white blood cells to interact with your vascular endothelial cells. It also is going to increase platelet activation. It is also going to increase white blood cell or leukocyte adhesion by all these ICAMs, VCAMs. And you're going to activate what's called a thrombin activated fibrinolysis inhibitor, so you can modulate this whole process. So then you have to get your fibrin made. And so fibrinogen is going to be cleaved to fibrin and form a soft clot. Sorry. So it gets cleaved. So fibrinogen is going to be both circulating in the blood and also released in your platelet granules. Your cleavage of by the thrombin protease is going to release these fibrin monomers, which then will aggregate. So you have basically your fibrinogen shown here. You have your site of your thrombin attack, so your thrombin protease. And then you're going to get your fibrin monomers, and these are going to aggregate. And you're going to get the formation of a soft clot. The next thing that has to happen is you have to get cross-linking of your monomers. So they are going to cross-link and form a hard clot. And you have factor 13A. This factor 13A is not a serine protease. And so factor 13A is going to catalyze a transamidation reaction of glycine and lysine. So here you have your transamination reaction, lysine, and you have your glycine. And so that is going to be what factor 12A is. It's not a serine protease. And so you get a 3D mesh of fibrin. And this is going to trap platelets and cells in this hard clot. Now this is table 45.2, and it just shows the different factors we've been talking about. It also labels the serine proteases, the ones that are not serine proteases, and then we also have regulatory factors. We're going to have thrombomodulin, protein C, and protein S, which are all going to be important in regulating this whole process. So just make sure you're familiar with what we've been talking about. We talked about the Stewart-Prouder factor. We've talked about which ones are serine proteases, which are cofactors, which are the actual enzymes. Now, one important thing is vitamin K. We haven't talked about vitamin K, but it's critical. So vitamin K is critical for clotting because a lot of the clotting factors are required to be modified in your liver by gamma carboxyglutamate. And so both prothrombin, factor 10, both contain 10 gamma carboxyglutamate residues that are going to bind to calcium. And so basically your vitamin K, you're going to have your glutamate residue, you're going to have your prozymogen. So this is even before it can become a zymogen. And it has to get carboxylated to form a zymogen. And so factors 7, factor 9, 10, and prothrombin all have to be carboxylated. And this is in the liver. And it requires vitamin K as a cofactor. So it's vitamin K dependent. Okay, and if this does not happen, then these factors cannot function, and they you will not form clots. So this is very important. Let's see if I want you to know anything more. No. Okay, now regulation of blood clotting. So thrombin has a prothrombotic role, and thrombin also has an antithrombotic role. And this is going to be feedback amplification. By factors 5, 7, and 11. And it stimulates its own production. And it's production by that tenase complex, which are that one, I should move it there. It also has the ability to activate platelet aggregation. And it also releases factor 8 from von Willebrand factor. And thrombin has an anti-thrombotic role. And it binds to thrombomodulin. Which stops the function of thrombin. And it also is protein C and cofactor protein S form an activated protein APC, which destroys factors 5A and 8A. Now, protein C is important in controlling coagulations as well as sepsis. Protein C gets cleaved by thrombin to active protein C. And then active protein C is going to cleave factor 5A and factor 7A. And so this results in termination of thrombin, and this is going to halt clot formation. This is important in hypercoagulopathy. So this control is important, and if you have hyper OAG, which is also thrombophilia, or factor 5 lead-in. And this is factor 5 is mutated and cannot be inactivated. Okay, so you can overclot. It's also important in sepsis, where you have your whole body is involved in an inflammatory response, so over active inflammation. And your cells in the immune system have receptors for active protein C. And so your active protein C can inhibit synthesis and release of pro-inflammatory cytokines. So you have a drug that's called Exris, and this is an antisepsis drug that targets the active protein C modulation of your immune system. And it can be used to treat some forms of sepsis. Now we also have antithrombin 2 and heparin. And so antithrombin, 3 is going to be amplified by heparin. Heparin alters conformation of antithrombin 3, which has a higher affinity for substrates. So this is a whole basis of using heparin as an anticoagulant. And I should also mention here that we have our serpins. These are serine protease inhibitors. And these are natural products. About 10% of the plasma proteins are these. And so antithrombin 3 inactivates thrombin, for example. Antithrombin 3 also inactivates factors 13A, 10A, 9A are also going to be inactivated. And plasmin degrades clots. And this is a highly regulated process. So plasmin is a serine protease. And your activated protein C releases from tissues plasminogen activators. So active protein C. And it also, active protein C activates the inhibitor of tissue plasminogen activators. And so tissue plasminogen activators can treat myocardial infarctions. So basically, also streptokinase has the ability to bind plasminogen. And so this can also treat myocardial infarctions as well. So streptokinase is an allosteric modifier to make sure that plasmin is formed. Okay, I'm not going to go over blood coagulation tests for time. You should get that in your clinics anyways. Clinical significance of all of this, we've talked a lot about all of these. Hemophilia A is the inability to clot blood. This is an X-linked disorder, and the deficiency is in factor 8. Has various degrees, severe to mild. You get hemorrhaging, easy bruising. Treatment can be to give factor 8. We have hemophilia B is inability to clot. This is a deficiency of factor 9. Prevalence is 1 of 10 of hemophilia A, so it's not as prevalent. And there's a lot of different variations of this. Fibrinogen and factor 13 disorders lead to cardiovascular risk levels. They also have elevated plasma fibrinogen levels. And so you have hyperproteinemia, hyperglycerinemia, etc. They can have inherited disorders where you have a lack of fibrinogen. So this is afibrinogenemia. Which is autosomal recessive. You also have hypofibrinogenemia. And this is where you have dysfunctional or reduced levels of fibrin. You also have dysfibrinogenemia. And this is you have dysfunctional fibrinogen. And you have factor 13 deficiencies, which is autosomal recessive. There's also von Willebrand disease, which you have a deficiency of von Willebrand factor. This is the most common inherited bleeding disorders of humans. You have type 1, which is autosomal dominant. Type 3 is severe recessive. And type 2 it can have either increased or decreased function. Okay, you also have factor 11 and contact activation. This is where you have that negative charge on the surface of your collagen or your extracellular matrix, and it triggers factor 11 pre-kallikrein and high molecular weight kininogen to interact. So defects in this lead to injury-related bleeding deficiencies. And this is common in our Ashkenazi Jews. We also have antithrombin deficiencies, and so this is autosomal dominant, and this is going to affect the stability of antithrombin. Treatment is going to be with heparin and anticoagulant therapies. So just very briefly about bleeding, you have inhibitors of vitamin K, which is going to impact your thrombin factors 7, 9, and 10. Seven, 9, 10, protein C, and S. All are dependent on vitamin K, and these are going to have the effect of inhibiting the reduction of the quinone derivatives of vitamin K to the active hydroquinone forms. You can also have activation of antithrombin 3. And these are glycosaminoglycans, heparin and heparin sulfate, used as anticoagulants. There are also plasminogen activators. Okay, and so that concludes our coagulation.